Oh, made that mistake twice. So I'm going to hand over today to Dr. Sam Morgan, who is our Women's Health Fellow at the BNSSG Training Hub, who has kindly put on this webinar for today. I'm going to hand over to Sam.
Great, thanks, Jeannie. Welcome, everybody. Fab to see so many faces. So yes, I'm Dr. Sam Morgan. I've been a GP for over 20 years now and always had a real interest in women's health. And a few years ago now, I trained as a menopause specialist. So it's great to see so many of you today. It's quite a varied audience, and this webinar doesn't assume any medical knowledge or understanding. For any clinicians who might be watching, you're really welcome too, and hopefully there'll be some useful learning for you. If you, as a clinician, want to know more about HRT, for example, there are some other webinars that I've recorded that are linked through the Training Hub website. So firstly, I just want to say something about language. Great to see that the title of the webinar was supporting people experiencing menopause. And I think it's important to note that not everyone experiencing menopause will identify as a woman. And certain groups within the menopause kind of sphere get quite underrepresented. So I acknowledge that I will be referring to women today, but the information really refers to anybody experiencing menopause. So to outline what we're going to cover today, I'm going to start by going through some terms, what the different terms mean. We'll look at the symptoms of perimenopause and how people might start to recognise what's happening. We'll think about some of the internal changes that take place, and we'll look at the impact of perimenopause on people and on their lives, their working lives, their family, their friends, their colleagues. And then we'll have a look at management options. So again, with this being a focus for the personalised care team, going to take a really good look at lifestyle. And there's a lot that you can advise people about that can make a really big difference. I will also talk to you a bit about HRT, so you've got some understanding as to what it can do and the pros and the cons. And we'll look at things like supplements as well. And I'm going to share lots of resources today, as well as a resource sheet that summarises them all later too. So you've got lots of places that you can signpost people to for reliable information and ongoing support. So let's get started with some definitions. So menopause, the change, the second spring, is basically that point in time 12 months after the last menstrual period. But like many things in menopause care, this definition doesn't work for everybody because not everybody will be having periods in the perimenopause. And the perimenopause is this time leading up to the menopause, where we start to see usually a change in our cycle if we're having one, together with a collection of different symptoms. The average age of menopause in the UK at the moment is 51, but 1 in 20 women will be menopausal by 40 to 45. And 1 in 100 women, those with premature ovarian insufficiency, known as POI, will be menopausal before the age of 40. A surgical menopause is where the ovaries are removed surgically, so this might happen at any age and can often be really difficult as the symptoms come on really abruptly. We might have an earlier menopause if we smoke, if we have a lower body mass index, with certain medical conditions like thyroid problems, and if we've had any treatment around the pelvic area, whether that's surgery or things like radiotherapy. A later menopause is often associated with having lots of children and also being on the pill for a long time. And often I'm asked if our mum's age of menopause might predict our own age, and there does seem to be a degree of correlation. If we have older sisters, the age of their menopause seems to be even more closely linked. And the average length of perimenopause is 4 to 8 years. So we can see if 1 in 20 women might be menopausal by 40 to 45, then 1 in 20 may well have symptoms in their late 30s and early 40s, perhaps far earlier than we might expect. Some people genuinely have no symptoms at all. Most do. And most of the time, those symptoms will settle, they will go. But some people are less lucky and symptoms can go on for 20 years plus, can even be lifelong. And with our average life expectancy as women in the UK being 83 at the moment, we're likely to be postmenopausal for at least 30 years or so. So again, part of this conversation for me is about supporting our health and well-being throughout that whole time, not just in the menopause transition sort of period. And it can be really difficult because sometimes perimenopause can start quite gradually. Sometimes it can be really sudden. The symptoms can sometimes be intermittent and come and go, and sometimes be persistent and be there all of the time. So it has lots of different ways that it can show itself. And this can make it really difficult for us as people to recognize what's happening, and also for our doctors and nurses to recognize it too. There are also really important cultural differences for us to remember. People from different races and cultures can experience menopause at different times and also in different ways. So, for example, the average age of menopause in women from Southeast Asia is 46 rather than 51. And there can be different sorts of understandings and thoughts about some of the treatments, for example, HRT. So, what might we notice? Well, there's no typical perimenopause, but perhaps what's most common in terms of symptoms is a cycle that changes and worsening PMS. And that cycle change can be quite subtle. It could be the cycle gets a bit longer. It could be the period itself changes in terms of something like the heaviness. Often there'll be more anxiety about the everyday, brain fog, poor memory, altered concentration. Fatigue can be really debilitating. People often say it's a bit like a jet lag sort of feeling. And poor sleep is common too. Joint pains, muscle aches, headaches, vaginal dryness and soreness is very common and really not talked about that much. And there are changes in body composition, reflecting these internal changes to metabolism that are starting to take place and have quite an impact for the future. And I've put hot flushes and night sweats at the bottom because they're the easy ones. Everybody knows hot flushes and night sweats. Everybody thinks menopause. But if we don't have those, if our main presentation is with more anxiety and poor sleep, it's easy for perimenopause not to be recognised. And hot flushes and night sweats often can be a bit of a later symptom. They peak about a year after our last period, by which time we may have had other symptoms for perhaps 10 years in the run-up to that. And there are many other symptoms too, not on this list, but other things that can happen. We don't usually get them all, but things like dizziness, palpitations, hair loss, dry skin, dry eyes. We can get restless legs. There's all sorts of different things. And very often people will have a cluster of their particular symptoms. And symptoms are usually what people will notice in terms of their experience. But as we've said, there's quite a few changes happening on the inside as well. And for our health, these are really important. So metabolism changes, and unfortunately not for the better. Our fat stores increase, levels of inflammation in the body rise, and we get this change in factors that affects our cardiovascular risk. And when we think about the top 3 causes of death for women being dementia, heart disease, and stroke, these changes are really, really important for our long-term health. So before menopause, women are quite protected from cardiovascular disease, and we have much lower rates than men, and then we quite quickly catch up afterwards. Bone density reduces too. Women reach their peak bone mass in their 30s and can lose up to 20% of bone mass in the 5 years after a period. And very few people tell me they worry about osteoporosis unless they've perhaps seen a relative experience it. But again, it can be a cause of a lot of disability and of difficulties in terms of living independently. If we have a fracture because of low bone density, some of those fractures will be quite minor, But fractures like spine fractures, hip fractures, can have a huge cost for us in terms of our health and well-being for the long term. And as women, we have an 11% lifetime risk of a fracture of our spine versus just 2% in men. So some of these fractures can be really significant. So in terms of experience at menopause, I think it's important to remember that no two experiences are the same. If we've had our own personal lived experience, it could be completely different from that of the person sat across the table to us. These are all quotes from women about their own experience. So I really thought I had dementia. I was so relieved when I found out it was just menopause. I thought I was depressed, and that was really scary, as I remember my mum having a deep depression when I was a child. I sailed through mine. I was just so relieved my period stopped, I don't really remember much else. I've never known tiredness like it. It was so gradual, it took me ages to notice something was wrong. And this can make it really challenging to recognise what's happening and quite isolating for people too, if they feel they have a really different experience to their friends, for example. So one person may be having such heavy periods, she dreads going into work for fear of flooding through her clothes and staining a chair. And somebody else may not be bothered by their bleeds at all, but may find the memory loss or the word finding difficulties absolutely excruciating. Somebody else may have lost such confidence, she thinks everybody can just see straight through her, she feels like a fraud. So the impact can be really significant and really varied. So overall, about 75% of people experiencing menopause will have some symptoms. These will vary person to person and can fluctuate over time. The effects on mental health can be really significant. They can be life-changing and life-threatening. We know that both deaths by suicide and divorce are most common for women between the ages of 45 and 55. Anxiety, low mood, rage, brain fog, low self-esteem are unfortunately all really common and can have a significant impact on the ability to work and to function. So if you're supporting a woman in her 40s with mental health concerns, perhaps think menopause, perhaps ask about her periods if you feel comfortable to. Ask if she's had any other symptoms that might help her to recognise that there could be a hormonal element. You could be that key person to help her recognise what's happening, which is always the first step in terms of getting the right support in place. And although menopause directly affects 51% of the population, symptoms can also have a really big impact on partners, family members, children, and colleagues. So just thinking a little bit about the impact on work. Well, interestingly, statistically, most women reach the peak of their careers at age 51, the same age as the average age of menopause. It's thought that women lose 10 years of their working lives related to menstruation, fertility, pregnancy, and menopause. The Fawcett report in 2022 showed that 10% of women had left their job because of their menopause experience. And then this increased to 22% of those who considered themselves disabled. Another 14% had reduced their hours, 8% had not applied for a promotion, and 26% had had some time off. And overall, 60% felt that there had been a negative impact on their work. And when we think specifically about menopause and the NHS employs over 1.3 million people, and around 1 million of these are women, and nearly 50% of the NHS workforce are women between the ages of 45 and 64, so likely to be experiencing perimenopause and menopause. So potentially a really big impact for ourselves and our teams and the people that we're working alongside. But the right support can make a really big difference to kind of mitigate that impact. There are some legal frameworks in place that can support people. So in terms of the Health and Safety Act for staff affected by menopause, this would be thinking that employers need to try and ensure people's health and safety at work. So making sure menopause symptoms are not made worse by the workplace or the work practices, and trying to make some changes to help people be able to do their job when they're having different symptoms. And again, the changes that people might need are really individual. There's no one size fits all. It could be thinking about flexible working patterns if somebody's having a lot of trouble with their sleep. It could be an extra set of uniform if they're having really heavy periods. Again, there's no standard set of alterations that are going to suit each person. The Equality Act has set out some protected characteristics, and in January 2023, we learned that menopause would not be added to these characteristics because it was deemed that it might discriminate against men who could have a long-term health condition. Disability in this context, though, means a physical or mental impairment for 12 months or more that may impact on our day-to-day abilities. And many people experiencing menopause would consider this would apply to them, that symptoms can certainly last for 12 months or more and can certainly impact on day-to-day abilities. And there have been an increasing number of employment tribunals related to menopause, with women winning when they can show they've perhaps been disadvantaged or treated less favourably because of their menopause symptoms, which can then be viewed as discrimination if it relates to a protected characteristic. So we all feel quite bleak at this point, thinking about all these different symptoms, all of these incredible impacts that it can have in terms of our lives, but there is a lot that we can do. So I want to move on now to think about what can help to kind of navigate this time. So we're going to kind of run through some of these different areas, thinking about information, looking at lifestyle particularly, and then talking about some of the medical treatments as well. And as we've said already, recognizing what's happening is really key. So as somebody supporting people, having kind of open conversations that might include asking about menopause, asking about potentially hormonal related symptoms, and sometimes be the first time somebody has thought about menopause, and can sometimes be quite a light bulb moment for people. For example, I recently met with a woman who was 46 who had a classical kind of perimenopause picture, and she told me how it was her young male line manager, who was just in his 20s himself, who had said to her, "I wonder if you might be in perimenopause." He'd been on a talk and she'd been having trouble with sleep and with some pain, and it was him who helped her to join the dots. And that can be so helpful for people just to understand about what's happening, just to recognize, okay, I know what this is. And that's the first step in terms of then thinking about making a plan. Reliable information. There's so much information out there now about menopause. It can be quite overwhelming trying to navigate it. Difficult to know what to believe, what to read. There's so much. So I think, again, supporting people to access the right information for them in their language, in a way that works for them to understand, again, I think is really important. And I'll share lots of resources that I find helpful to share with people later. And support from others too. Again, I'm going to share a leaflet for support for partners around menopause. Some resources for workplaces. Again, I think it can be quite an isolating time for some people going through menopause. So having a team around you, having people who get it, who know, again, is really helpful. Lifestyle can make a really big difference, both in terms of symptoms and experience, as well as the long term. So we'll take some time to look at these different areas, sleep, nutrition, movement, and rest, in terms of how they can support people at menopause. And it can be a really important time, and often a time where people are really receptive to thinking about their health. So things like smoking cessation, it can be a really good time to introduce that. As we've said, things like our cardiovascular risk really goes up quite significantly around this time. And people notice they're starting to put on weight around their middles. Their blood pressure might be starting to go up. So often they're receptive to thinking, perhaps this is the time where I really need to get that exercise routine sorted and need to think about cutting down on smoking and alcohol. Stress has a really big impact, and we'll talk again about what we can potentially do to support people with that. And then I'll introduce you, as I say, with some headlines around different medical treatments. So I'm going to start by looking at sleep. So at perimenopause, about 50% of women will notice some sleep changes. There tends to be less sleep, it's of poorer quality, and there are more nighttime wakings. And this can directly impact symptoms, particularly things like the cognitive symptoms, so the brain fog, the poor memory, the word finding difficulties, tiredness obviously too, and low mood and anxiety as well. It can also affect weight particularly too. So supporting sleep directly can really help people if these are their main symptoms. So again, if you're seeing somebody who's anxious and has a low mood, if you know they're struggling with sleep, then supporting them around looking at that could really help with those symptoms, even if you don't directly do anything to change their estrogen levels. So if we're thinking about supporting somebody with sleep, the sleep hygiene rules are really useful to look at. So those kind of set of guidelines around trying to be in a good routine with our sleep, trying to keep our caffeine to just in the morning, trying to get out for a walk, for example, in the morning. So we have some to help our melatonin secretion for the next night, avoiding screens in the evening. So if you have children, probably all the things that you're trying to support your children to do to sleep well. So always worth looking at the basics, and that can definitely be helpful. If somebody does have full-on insomnia, good sleep hygiene often isn't enough on its own, unfortunately. And so there is a type of CBT, which is available on the NHS, CBTI. So here locally in BNSSG, we can access it through SilverCloud. People can also access Sleepio through their NHS app. And that's been shown specifically to be effective for the sleep disturbance of perimenopause. Some people try magnesium as a supplement and sometimes get on quite well with that. There are non-hormonal treatments like some of the antidepressants, which can be sedative and can support sleep. We definitely don't want to be looking at kind of sleeping tablets and things. They're not usually the answer at all. And if somebody is having a specific sleep problem, supporting them to see their GP. If they've got something like restless legs, there are some specific treatments that can be helpful. And then moving on to nutrition, I think again, it's an area where there's so much information and often a lot of conflicting things. So it can be difficult for people to understand what the right things might be to do. So to think about what we know from the evidence, from the studies, we know that people who follow a whole food, plant-based type of diet tend to have less symptoms at perimenopause and also have lower rates of heart disease, diabetes, cancer, and low mood. We know that our bodies produce hormones from fats, so good fats from things like nuts and seeds and avocado, extra virgin olive oil can be helpful for hormonal symptoms. We know that the microbiome plays a role and changes at perimenopause, and so supporting the gut microbiome, these trillions of organisms in our gut, by having lots of different fruit and veg, having lots of fiber in our diet can be helpful too. You can get estrogens from plants, so things like soy contain phytoestrogens, plant-based estrogens. And some people get a really good benefit from these in terms of improving their symptoms. Other people, unfortunately, don't get any benefit at all. It depends on our genetic makeup as to how we metabolize that soy, as to whether it might help us or not. But for some people, it can work a treat. Vitamin D, especially through the winter months, is important for our bone health. And thinking about alcohol, smoking and caffeine. Alcohol can have a real impact on symptoms, particularly, again, anxiety and low mood and sleep disturbance too. Caffeine can have similar effects as well, and both alcohol and caffeine can worsen things like hot flushes too. So sometimes encouraging people to perhaps try without or with less if they don't feel to go without for, maybe a month or so, and just to notice if that might improve their symptoms can be a really useful intervention to suggest. In terms of supplements, again, it's big business now, supplements. There are so many out there and so many people are taking lots and lots of different supplements. Many people feel more confident in supplements than they do with prescribed medication. In terms of what we know, there are some that do show some evidence that they can help. So things like black cohosh and red clover have an effect. They're called isoflavones, so they have an effect a little bit like soy can and can help with a lot of the different symptoms. They're not advised in breast cancer because they do have a direct impact on estrogen levels. St. John's wort is used a lot on the continent and can help with anxiety and depression and also hot flushes, interestingly, but it does interact with HRT, so shouldn't take it alongside HRT. And ginkgo sometimes can help with some of the cognitive kind of symptoms, but it seems to be really a short-term effect. There are lots of supplements that are sold as being kind of menopause supplements where there's no evidence of any benefit at all. So again, it can be quite a tricky kind of place to navigate in terms of figuring out what might be good to try and what is less likely to be helpful. Coming on to think about movement, supporting people to be exercising and moving. Well, again, there's definitely evidence to show that exercise can really help with symptoms. Also, again, can help for the long term by thinking about protecting our hearts and our bones. So it can make a difference to symptoms and also really support health for the long term. There's one study of women in their 40s, which showed that those with really high fitness levels were diagnosed with dementia on average 9 years later than those in their 40s with lower fitness levels. So again, some really important kind of things to think about for the long term. Joe Wicks has recently uploaded some free strength training videos to his YouTube channel. And I also quite like Rangan Chatterjee's 5-minute kitchen workouts. So some of these just really simple workouts that people can do at home where you don't need much equipment, you don't need to be a member of a gym. Just doing some regular strength-based work at home, again, can be really useful for that bone density, for that metabolism as a way of supporting symptoms. And again, for the strength training particularly, even 5 minutes 3 times a week can make a difference. So it doesn't need to be, an hours long run. It can be these short amounts of movement that we can try and build in. Rest, I think, is really tricky. I think people at menopause are often pulled in so many different directions and often focused on looking after everybody else. Parents, children, running the household, working, and some people put themselves at the bottom of the list and find it really difficult to self-care and are just always on the go. And if we think about somebody who might be experiencing burnout versus perimenopause, there can be a lot of similar symptoms. We know that stress can have a really direct impact on our symptoms, that it can really magnify things. Work stress can too. And there's also evidence to show that if somebody's experienced trauma in the past, that they're more likely to have worse symptoms around their mood at perimenopause. It sometimes feels as though any kind of hormonal shift can expose any vulnerabilities, and sometimes past traumas can really suddenly resurface at this time, and again be really difficult for people to understand why something from years back is suddenly right there again. So again, supporting people to have permission to stop sometimes, to prioritize their downtime, their rest, I think can be really, really helpful. And on a similar theme, it can be quite an isolating time. People can have this experience where they might feel really irritable, they're shouting at their partner and their kids, and they just don't recognize themselves. They think, well, where has this come from? This isn't me. What's going on? And that in itself can be really difficult to cope with. And encouraging some self-compassion, encouraging people to try and cultivate a bit of kind of awareness as what's happening, and acceptance, if they can, to kind of recognize what's happening, again, can be useful. Encouraging people to spend time with people who top them up, who kind of really support them, and doing things that they enjoy, doing things that nourish them, to balance some of these challenges. So a sort of run through of a framework of ideas around lifestyle that have been shown to be helpful in terms of symptoms. Before we move on to looking at medication, I wanted to talk about CBT as well. It gets quite a negative press sometimes, I think, in terms of thinking about CBT for menopause, but there is some evidence that it can be helpful with things like low mood and anxiety and sleep, but also with symptoms like hot flushes and night sweats. I used to feel quite skeptical about this, but I've spoken to lots of people who have had a really positive impact. This book is an evidence-based guide for people to look at a CBT approach through menopause. And there's also a leaflet by the Women's Health Concern, who are the patient-facing arm of the British Menopause Society. Here in BNSSG, obviously people can self-refer for general CBT. There isn't a specific CBT for menopause that we have available locally. So I'm going to give you a little bit of an overview about HRT over the next few slides, because you might get asked some questions, it might come up sort of in terms of conversation, and there's still a lot of myths out there around HRT. So just going to introduce you to it with some headlines. So when we think about HRT, estrogen is the main hormone that helps with our symptoms. It can be given as a tablet, as a gel, as a spray, as a patch. If we have a womb, we need to use progestogen alongside that estrogen to protect the womb lining. And again, that can be given as tablets or patches, or also as a Mirena coil. Testosterone is sometimes added to support libido. And then there's local estrogen, which is estrogen that can be used around the vagina to be really helpful with kind of vulval and vaginal symptoms and bladder symptoms too. So it's a tiny dose of a very localized estrogen that can really help with those symptoms. And I think we have this natural negativity bias, don't we? We often want to go straight into the side effects, the risks, what harm is this going to do? But I want to just talk a little bit about some of the positives. So for most people who try HRT, if they're having symptoms, it will help with those symptoms. Studies have shown that if people start HRT before age 60, so before 10 years after their natural menopause has happened, the mortality rate, the death rate, is lower. And mainly that's because of this effect that it has for the heart and the blood vessels. So it helps to protect us against cardiovascular disease. It can also reduce the risk of osteoporosis and bowel cancer. And if it started within 5 years of our natural menopause, may reduce the risk of dementia. This is being looked into more at the moment, so we can't say this for sure right now, but it's being looked into. And I remember being taught about these benefits by a gynecologist at med school back in the 90s. And at the end of his talk, I can remember he asked us, so what percentage of women do you think use HRT? And I remember thinking, well, that sounds like quite a good list of benefits to me, maybe 50%, and being surprised when he said 10. And currently in the UK, even in the age of Davina, we know around 14 to 15% of women in the UK who are eligible to use HRT are currently taking it. And this varies really significantly with both deprivation and with ethnicity. So we see huge variations across Bristol, for example, in terms of HRT prescribing rates. And partly that's because some of the myths that are still around. So There's still quite a lot of misinformation around who can and can't use HRT, and risks are different for different people, and they're different with different types of preparations. So, for example, if somebody has had a blood clot, there's certain types of HRT I definitely wouldn't want to prescribe for them, but there are other types that are much less risky. There are no arbitrary time limits now, so it can be used for longer than 5 years if that feels appropriate. It can be started in the perimenopause if we're still having periods, and it can potentially be started over the age of 60 if we're having troublesome symptoms. Over 60, we wouldn't get those protective benefits that we've talked about for the heart or the brain. It can still help with the bones, and it can still help a lot with symptoms. The main worry I hear from people around HRT is breast cancer, which I absolutely understand. A woman's lifetime risk of breast cancer is 1 in 8. It's common. Most of us know somebody who has had breast cancer or is undergoing treatment. It can feel like it's all around us, and that can be quite frightening. And when people hear about links between HRT and breast cancer, that can put some people off immediately. This is a chart that looks at risks from our lifestyle as well as looking at risks from HRT. I'll talk you through it. I think it's quite helpful. For me, it's helpful in terms of putting these different risks into perspective. So the top line is the baseline, and it says, well, if 1,000 women aged 50 to 59 were looked at for the next 5 years, 23 of them would be expected to be diagnosed with breast cancer. And then with the lines further down, it essentially looks at that same group and then if something else happened. So if they were given older types of combined HRT, we'd see 4 extra cases of breast cancer. If they were able to have estrogen-only HRT because they didn't have a womb, they'd had a hysterectomy perhaps, there are 4 less cases than the best baseline. 4 extra cases with a combined pill, 5 extra cases if we drink 2 or more units of alcohol a day, 3 extra cases if we smoke, and 24 extra cases, so the risk more than doubles if our BMI is over 30. 7 less cases if we can manage 2.5 hours of moderate exercise a week. It's estimated that around 23% of breast cancer cases at the moment are linked to lifestyle and 2% to current or past HRT. So sometimes actually looking at our lifestyle and perhaps moderating some of these things if we can make a really big difference to our overall risk. So just a little bit of thought there around what these risks are, just to help you put them into context. I don't, though, want to think about this being a blame game. There's lots of people who get breast cancer for lots of different reasons, and yeah, again, I think sometimes it can feel really hard that if we're carrying extra weight ourselves, that we don't deserve to get breast cancer. It's really just to help understand what these different risks are. Just to mention the HRT prepayment certificate, again, just so that you're aware of it. It came out in April the year before last. More than 37,000 were purchased in the first 3 days. The website crashed. And essentially, it was one of the things pushed through by the all-party parliamentary group on menopause, recognising that prescription costs were a real barrier to some people. So especially with, for example, just 1 month of a combined patch attracts 2 prescription charges for just 1 prescription. And the prepayment certificate effectively is 2 prescription charges for then a year's worth of standard HRT. And it covers most of the preparations, not all of them, but most of them. The typical prepayment certificate does still cover HRT as well. So if you do have that one, that still works for HRT too. But if somebody isn't having other medication, this can potentially save them quite a bit of money. And you can get them from the NHS Business Services Authority website, which again, I'll link to from the resource sheet. And then also just to let you know that there are options of non-hormonal medication if people can't or don't want to use HRT. Not everybody wants to take it, and that's absolutely okay. Some people, for example, if they're undergoing treatment for breast cancer, may not be safe for them to take it. And there are non-hormonal treatments like some of the antidepressants that actually can really help with some symptoms. These treatments mainly are good for things like hot flushes and night sweats. They don't necessarily help with all of the different symptoms, but there are some options there. So again, encouraging people to speak to their GP if they're struggling, because there may well be options that they can look at, even if they've been told they can't have HRT. And excitingly, there's actually a new drug that's been specifically designed for menopause that's just been approved. So fezolinetant works directly on the kind of the thermostat control in our brain. And in the studies, it switched off hot flushes for people who took it within a couple of days, had quite a remarkable response. So it's undergoing its hopeful approval with NICE at the moment. So it's something that hopefully will come in the next few months. Otherwise, they're mainly treatments that have been used for something else and have been shown to also work for hot flushes incidentally. So in terms of resources, as I said, I'll send you through a sheet that's got lots of different things on there. A couple of things I just thought would be worth highlighting. So the Women's Health Concern are the patient-facing arm of the British Menopause Society. They've got a great range of leaflets about all sorts of things like nutrition, emotional wellness, movement, supplements, as well as lots of leaflets about HRT. Rock My Menopause are the patient-facing arm of the Primary Care Women's Health Forum. I'm not convinced by the name, but again, they've got lots of good resources. This QR code gets you to a leaflet from a group called Menopause Support, and they also have a leaflet that I think is really helpful for partners about understanding what somebody might be going through, with some sort of practical suggestions of things that can help. People experiencing menopause in their 20s have completely different needs to somebody experiencing menopause in their 40s or 50s. And so this is a little sort of summary of some useful resources for younger people experiencing menopause. The Daisy Network are a great support group. There's a link to a leaflet that's available in lots of different languages, a couple of books, and a Mothering in the Menopause support group. So again, the challenges of navigating premature menopause as a young woman when you're also perhaps supporting toddlers, again, is quite a different experience. And this is run by a local mum, a health visitor, just outside Bristol. And I mentioned already, I think some people can feel really marginalised by the kind of the conversation around menopause that often focuses on white, middle class, cisgender, heterosexual women. Black women in menopause are a really important patient support group, as are queer menopause, who are here to remind us that menopause affects people. People who've experienced surgical menopause, as we say again, have slightly different needs, and there's a specific support group there. Empower is a great group that runs up at the Greenway Centre, up at Southmead. They meet once a month, a group of lovely women who just chat all things menopause. And links also here to some leaflets to support people with learning disabilities, and some leaflets generated by the University of Bristol to support communities in Bristol with different languages. If I've triggered some interest in you and you want to do a bit more, e-learning for health have a menopause awareness module that's really good, and it again gives a nice broad overview. The British Menopause Society have loads of resources on their website and lots of good videos that are kind of really accessible. One here that's linked is just Menopause Explained, so a 5-minute video with an experienced specialist just talking again about different aspects. And as I've mentioned, there are other menopause webinars, particularly with a clinician focus, that are linked from the Training Hub website. So I hope that's been helpful. Thank you for your interest. Thank you for all you do in supporting your patients. I'm really happy to share the slides. I'll send round a kind of resources sheet over to Jeannie, and happy to take any questions.
First of all, I'd just like to say that was absolutely amazing presentation. I've done independent research about menopause, but never anything quite so informative. So that's great. Thank you very much for that presentation. I think it really shows how important it is. I didn't realise quite how much of the NHS staff, I suppose, that this would affect, and so should be a higher priority, I suppose, than it is. Hopefully we can all do some work on that. Are there any questions from the chat? You can either put your hands up if you'd like to ask, or popped it in the chat, whichever works best. Got a hand up from Sarba James.
Thanks, Jeannie. Thanks so much for that. That was fantastic. I do have two questions, cheekily. One is about how long women should take HRT for. When I've supported patients, they're like, can I take it for the rest of my life, especially for bone density and cardiovascular risk? Some GPs seem to recommend 2 to 5 years. I wondered what your opinion was on how long to take HRT for, and whether you tailor off or how you manage that.
Yeah, thank you. It's a really good question. And I think, as ever, it depends. There's different things that are right for different people. We used to say 2 to 5 years because we were worried about some of the risks of HRT. I think we're much less concerned generally about the risks now. It is recommended to have an annual check, to have a think about that benefit risk ratio for that individual, because some people's risks will be higher than others, particularly if they've got a very strong family history of breast cancer, for example. But some people are choosing to take it long term. I think, again, particularly if they have a lot of risk factors for osteoporosis and have a very low risk in terms of HRT, they may feel it's right for them to take it long term. For symptoms, if somebody's mainly using it for symptoms, I often say, well, use it for 5 years or so, and then have a think about what feels best for you. Some people might try without it and see how things are without, from time to time, perhaps once a year, try without it for a month and see. Some people might choose to use it through their working lives and then perhaps try without if they've come to retire and it's a less impactful time then to try without. The local HRT, the local estrogens, I would say to carry on with lifelong. So if you've had really bad vulval vaginal symptoms, lots of UTIs, I would not stop the local estrogen because those symptoms virtually always come back. They don't usually go away on their own. So those would be different. But yeah, I hope that helps.
That's brilliant. That's lovely and personalised as well. I like the fact that people kind of work out benefits versus risk, and there's that assessment. So thank you. The other question was experience on running groups. We're looking at potentially running menopause groups in GP practices. Is that something that you're involved with, or have any top tips or anything to share?
Yeah, I can put you in contact with Nikki Atkins, if you haven't heard of her already, who runs groups at the Leonard Surgery in Bristol. She's been running them for the last couple of years, really great feedback, and she's really happy to share her experience with people. She has a nurse background, currently works as an HCA, and has been really proactive in terms of contacting patients and running kind of group sessions. I think group consultations potentially could work really well for menopause. I went to a training session myself around that recently, and there's lots of resources being developed nationally around looking at this because I think it could work brilliantly. So I think patient education sessions can work really well, and then group consultations potentially for the more medical side can be really effective too.
That's helpful. I'd love that contact. Thank you so much.
Yeah, no problem.
Fab. Thank you very much. And we come down to Sandra.
Hello. Thank you so much for the session. It's been really informative. I'm sort of interloping. I'm on the graduate management training scheme, so I got invited that way. But my questions are really about me, actually. But I hope that it's kind of a bit more broadly useful. So I was one of those people that felt like I had dementia. And it really, and the brain stuff really affected me. I mean, I did have hot flushes and all that kind of stuff, but I could deal with all of that because I could just put a fan on or whatever. But when I started losing my ability to speak, forgetting words. I forgot the word for teams at one point and had to try and remember stuff. So that was really, really hard. I went on HRT. I was on HRT for about 9 months, and then I started bleeding, and I've since been diagnosed with a typical hyperplasia. So I'm going down the hysterectomy route. But so I was told to stop all HRT, but I was really up for all the benefits that you described. Health, all of that kind of bone density and all the rest of it. And I was really afraid, particularly being on this management training scheme, that I was going to lose my mind again. So I've been spending loads on vitamins, kind of calcium and ginseng and all sorts of stuff. And I just wondered if you know what things are kind of, is there anything that's better than something else? And, is it, do you have any advice really?
Sure, yeah. Thanks for sharing your experience. And yeah, I think those symptoms around our cognition can be really, really difficult ones. They're quite hidden, aren't they? And we feel them, and they really affect our sense of self and our confidence, and can really impact on our abilities to kind of work particularly. It's really hard, isn't it? That's right. You kind of hear all these benefits of HRT, and then if you're told you can't take it can feel really difficult, like you're kind of missing out on this, this kind of wonder drug with all of these different effects. But I think in terms of things that can make a difference, particularly with cognition, I think, again, I'd start with lifestyle, and I'd start by thinking about that kind of framework of looking at sleep, looking at nutrition, looking at movement, looking at rest, kind of really just going back to basics. And often I encourage people to kind of self-rate a little bit, maybe give yourself a mark out of 10 about where you think you're at for each of those areas, and focus on the one with the lowest mark, because you've got most to gain by looking at the area where perhaps you're doing less well in that area at the moment, if that makes sense. Often we tend to focus on the bit that we're most interested in. So some people are amazing at cooking, and so will already have a great diet, but might make that already great diet even more brilliant. But you're going to get less reward than if you perhaps are sleeping 3 hours a night and can gradually push that up a little bit. In terms of supplements with cognition, as I say, Ginkgo has a little bit of evidence. There's not much evidence for most of the others, but there is evidence that better sleep helps, that downtime helps if we're feeling kind of stressed and overloaded, that things like strength training can help with our kind of clarity of thought and our concentration. So that's where I'd start, rather than necessarily pinning all your hopes on one supplement.
Thank you.
Lovely. Thanks for that. Does be such a broad approach, isn't it? You've really got to work out what's good for the patient in front of you, and that's why this kind of like personalised care approach. We've got lots of staff here from the personalised care roles across other roles within BNSSG, but lovely to have that opportunity. Are there any other questions? I'm just going to check the chat in case anyone's popped anything in there. No. Oh, we've got Sam. Sorry, Susan. Can't read today apparently.
Hi. Oh, just a quick question. I wondered if you would be happy for me to share your slides with other people in my organisation. In particular, I'm part of a group who are working on a menopause policy for our organisation. Is it okay to share those? Thank you.
Yeah, that's fine with me. Thanks. Yeah, there is a Menopause in the Workplace webinar that's recorded through the Training Hub, and there's a link of resources with that one with lots of examples of kind of workplace related resources, so that might be useful to look at as well.
Thank you.
Fab. Any more for any more? Lovely. Well, thank you very much for all coming along today. I'm going to stop the recording.